DB-05 a little bit. Heterogeneity.
We're really just trying to confuse everyone about the numbers here.
I know, yeah. And DB-05, I'll remind everybody who's listening to this, is T-DXd versus T-DM1 in patients with residual disease after neoadjuvant chemotherapy.
And not just residual disease, residual nodal disease.
Disease, a high-risk population, not everybody. Thank you for correcting that. Heterogeneity of disease. I know there's some data which suggests T-DM1 may not be as active in tumors that are very heterogeneous. We have not seen that level of data yet from 05, but do you anticipate there to be any issues with heterogeneity?
No, in fact, I actually feel more comfortable giving trastuzumab deruxtecan in heterogeneity than I do T-DM1, right? I mean, we know that T-DM1, you really need a high HER2 expression to respond, yet in Catherine, even the people that had converted to HER2 negative at the time of surgery still benefited from giving T-DM1. So I actually feel even more comfortable with trastuzumab deruxtecan now that we've got it for 2+, 1+, and now to 0 with some staining, that's going to be a good strategy.
So does that change your mind about DB-05?
Oh. No.
Does it influence your 2+ HER2 positive that barely meets ratio of positivity?
Yeah.
Are you thinking then T-DXd, is that going to influence it versus
Maybe,
a 3+
actually.
expression?
Yeah, maybe.
Yeah. See,
And the ER positives,
and the ER
right? I mean, they're
positives,
going to
you have
have
to-
a lower PCR rate
right.
a little bit,
Yeah,
right?
which means that you're going to have to force to think of giving them AC.
I know.
That is
I know.
going to be interesting. HER2 scoring and the current assay that we use was really not developed or designed to check for ultra low or low. It really was validated in the 3+, really meant for, designed for 3+. Do you think we need another test
I mean,
to help that?
I think in an ideal world, yes, right? I mean, the question, and this is, provocative, the question is there really a population in breast that doesn't benefit from trastuzumab deruxtecan, right? I mean, I don't know. It's probably small. And the problem is that we have such heterogeneity. When we biopsy somebody, we're only looking at one tiny spot within one lesion, and we don't know what's going on in the rest of the body, right? It's not like it's circulating tumor DNA where we can accurately get, a HER2 status on every, spot, every area of the tumor, right? So, I mean, I do think that this is actually one of the opportunities for AI, to use a buzzword. But, there's a lot of AI strategies looking...
digital slide reading using AI? Okay.
And different ways of capturing HER2 that's not just IHC, right?
All right.
More quantitative methods instead of qualitative.
I often say, theoretically, there really shouldn't be a HER2 negative cell because that HER2 pathway and protein is important for normal cell function.
Right.
So it's really about the assay and its ability to really detect low expression of HER2. So we should be able to have activity. In retrospect, I think if you're designing a T-DXd study, you're probably using all comers.
Yeah, I actually in my clinic have told my NPs that I don't want to hear HER2 negative anymore. You're HER2 positive, you're HER2 low, you're HER2 ultra low, or you're HER2 null. There's not a negative. It doesn't mean anything anymore.
Yeah, and so I think ultimately that's where we should move with new HER2 testing.